So good morning, good afternoon, good evening. So basically, I presented yesterday this very large study on almost 20,000 transplant for Hodgkin lymphoma on behalf of the EBMT Lymphoma Working Party. So as you know, autologous stem cell transplant is standard of care for chemosensitive Hodgkin lymphoma in relapse after frontline therapy, and allogeneic transplant is a standard of care for patients who fail a prior auto. So in this study with a very large number of patients, almost 16,000 auto transplant and 4,000 allo transplant, we observed a steady increase over time in outcomes, improved progression-free survival, and overall survival, mainly due to decreased incidence of relapse. So when looking to answer your question, when looking to the reasons behind this improved outcome, we can distinguish what happens in autologous transplant and in allogeneic transplant. So in autologous transplant, over time, we are transplanting more patients in complete remission, more patients who are PET-CT scan negative at the time of transplant, and less frequently patients who are in with active disease, PET positive, or refractory disease. And when we look to the outcome for patients in complete remission over time, there is no change. So the improvement in outcome after autotransplant can be explained by the fact that we are transplanting more patients in CR. And when we look to the treatments used before transplant, we can see that we have over time increase in the use of brentuximab vedotin, and explaining the increased rate of CR at transplant and the improvement in post-auto-transplant outcome. The situation is quite different for allogeneic stem cell transplant. So here also, we are transplanting more patients in complete remission, and these patients are being allografted after prior exposure to brentuximab vedotin or checkpoint inhibitor, with a tremendous increase over time in the use of these antibodies before allotransplant. However, if you take patients in complete remission at the time of allotransplant, their outcome is improving over time. So the improvement in allotransplant cannot be solely explained like it was the case for autotransplant, with the fact that we are transplanting more patients in CR, but it has to do with improvement in transplant techniques. So we explored three aspects. Over time, we have seen that more and more patients are allografted after prior exposure to checkpoint inhibitors. And when we look to the outcome of patients allografted after checkpoint inhibitor, yes or no, you can see that pre-exposure to checkpoint inhibitor decreases the incidence of relapse after allotransplant and improves progression-free and overall survival. Also, we are more frequently using post-transplant cyclophosphamide for GVHD prophylaxis. And here also, we can see that patients who receive post-transplant cyclophosphamide have decreased incidence of relapse and improved survival. So overall, the improvement over time in survival post-allotransplant is not only explained by the fact that we are transplanting more patients in CR PET negative, but also to the fact that we are transplanting patients after prior exposure to checkpoint inhibitor and using post-transplant cyclophosphamide for GVHD prophylaxis. This is a very open question. We have multiple commercially available CAR T-cell products, so it depends what type of target. The most frequent target in B-cell non-Hodgkin lymphoma is CD19, so we have commercially available product, CAR T-cell product targeting CD19. We have Tisa-cell, Axi-cell, Liso-cell, and mostly used for diffuse large B-cell lymphoma, and Brexi-cell for mantle cell lymphoma. In addition, we have also multiple academic CAR T-cell products that are being developed in different parts of the world. To give an example, we have the ARI1 product developed in Spain, in Barcelona. The characteristics of the product are quite different in terms of the lentiviral vector used to produce them, the intracellular domains, the T-cell activation markers. So some products are associated with higher efficacy, but also higher toxicity as compared to other products. So we don't have actually a head-to-head comparison in a randomized trial between the products. We have studies, retrospective studies, or inter-trial comparison, which in my sense is not as solid as a randomized trial.